Start this one. Good morning. Today we'll be discussing about typhoid. Before we discuss about typhoid, yesterday you should have class about dengue. I'll ask some questions about dengue, which you need to find out the answers and make a note of it. Uh, dengue is caused by dengue virus. Belongs to which family? Uh, just find out which family does dengue virus belong, and what is the pathophysiology of dengue. I mean, the way it will lead to dengue hemorrhagic fever or dengue shock syndrome. What is the pathophysiology behind it? Why there is a capillary leak in dengue? Then what are the signs and symptoms of dengue? And what are the warning signs? What is the classification of dengue? What are the warning signs of dengue? And what is the treatment of dengue? Okay. Now I will be proceeding with typhoid. In India, it is the most common cause of pyrexia of unknown origin. So, in cases of pyrexia of unknown origin, that means you have not diagnosed the fever for more than 7 days on OPD basis, on IPD basis, and for more than 2 weeks on OPD basis. That is known as pyrexia of unknown origin. In that situations, typhoid is one of the most common cause for pyrexia of unknown origin. That is 2 weeks on OPD basis and 1 week on IPD basis. If you have not diagnosed the fever, then first thought you should go for typhoid, and the second one might be UTI. So typhoid and UTI are the most common causes of pyrexia of unknown origin. Typhoid is also known as enteric fever, as you already know, which is a misnomer, as it was thought that it only affects the intestines. Basically, typhoid is a fever which affects the endothelial system. It not only affects intestine; it will affect all the other organs of the body. So, it is a misnomer to say typhoid is an enteric, also known as enteric fever. So, what are the organisms? We all know this, I guess. Organisms are Salmonella enterica var typhi, and paratyphoid fever is caused by Salmonella enterica var paratyphi A, B, C. Three serotypes are present. Paratyphoid infections constitute about 20% of all cases of enteric fever. So let's know something about the bacteria itself. Salmonella enterica var typhi or paratyphi is a gram-negative, non-lactose fermenting flagellate bacteria. Somatic or O antigen is shared among various types of salmonella. That means it is shared with typhi, with paratyphi, and all the other all these bacteria belong to the genus Salmonella. Whereas flagellar or H antigen is specific for Salmonella enterica var typhi and also possess a VI polysaccharide capsule. So this is the basis for the recognition of typhoid fever in Vidal test, which we'll be discussing a bit later. What is the mode of transmission? Mode of transmission is fecal-oral route. Infective dose is 10 power 3 to 10 power 6 organisms. Incubation period is 7 to 14 days. Risk factors. So it is fecal-oral route. So you have to eat or drink something which is contaminated. So contaminated food and water is one of the risk factor. And floods. During floods, the contamination is more common. So flooding is the one of the risk factor. Lack of hand washing and toilet access. That means, in simple words, lack of hand hygiene. And patients on antacids, on proton pump inhibitors, decrease acid secretion. So bacteria in less dose only can cross the gastric barrier. So we have already studied that 10 power 3 to 10 power 6 organisms are required to cause the typhoid disease. But in case, and we also know that gastric acid, this acid acts as natural barrier for the infections. So if the patient is already on antacids or proton pump inhibitors like pantoprazole, lansoprazole, or omeprazole, esomeprazole, anything like that, that will decrease acid secretion. So less quantity of bacteria is enough to cause the disease. So now what is the pathogenesis? Bacteria crosses the gastric barrier, reaches small intestine, penetrates mucosa and infects lymphoid follicles. So it is as simple as that. First bacteria passes through the gastric barrier, then reaches small intestine, penetrates lymphoid follicles, drain mesenteric lymph nodes and reaches liver and spleen. In liver and spleen, they start multiplying. Multiplies in reticuloendothelial system. Here the incubation period. From here, this is the primary bacteremia, and now the secondary bacteremia occurs, and then the clinical manifestations. So when it takes 7 to 14 days, that is the incubation period in multiplying in reticuloendothelial system, then spills into bloodstream and disseminates into various organs like liver, spleen, bone marrow, gallbladder, and Peyer's patches, and leading to the clinical manifestations. Clinical features. There is no difference between typhoid and paratyphoid fever. Stepladder type of fever is a hallmark. Fever starts as a low grade and then increases to high grade fever by the end of first week. High grade means it will be around 103 to 104 degree Fahrenheit. And this is how we can differentiate this from a viral fever. Viral fever starts with high grade, then it decreases over the period of 1 week. And viral fever, child is normal in the interfebrile period. Whereas in bacterial fever, that is like typhoid, a child is not normal during the interfebrile period. Child will be sick looking. And infants and young children, diarrhea is the prominent symptom. Fever may be associated with malaise, dull headache, anorexia, nausea, vomiting, abdominal pain, diarrhea, constipation. Constipation is rare in children, but you would have studied that there might be pea soup diarrhea with alternating constipation in your medicine textbooks. But whereas in children, coming to children, constipation is rare in children. This picture shows coated tongue and rose spots. These are the examination findings in typhoid fever. Examination findings. Child looks sick looking, that is toxic appearance, coated tongue, relative bradycardia. So what do you expect when the child is having fever? When there is hypothermia, there should be tachycardia. But in this child, there is relative bradycardia. Due to the toxins and a little toxin secreted by Salmonella typhi. And not only that, it also causes myocarditis, which is leading to relative bradycardia. Hepatosplenomegaly, rose spots. Rose spots are macular or maculopapular rash visible around 7th to 10th day of illness on lower chest and abdomen and last for 2 to 3 days. This is not seen in Indian children. This is actually seen in only textbooks. It is not seen in Indian children because of the dark complexion of the children. Natural course of illness. Fever may continue for up to 3 to 4 weeks followed by natural remission or by development of complications. Complications. Typhoid affects almost all systems. The commonest intestinal complications, that is bleeding and perforation, are rare in children. Bleeding is caused due to erosion of necrotic Peyer's patches through vessel wall. So it affects almost all the systems. Complications. You just add itis to anything, that is a complication of typhoid. So let us see the detailed complication list. CNS, it might cause encephalopathy, convulsion, psychosis, GIT, hemorrhage, perforation, peritonitis, hepatitis, cholecystitis, cholangitis, hepatic and splenic abscess. Respiratory system, early it might cause bronchitis, late secondary pneumococcal pneumonia. Cardiovascular system, myocarditis, which can be diagnosed due to relative bradycardia and systolic murmur. Skeletal, it is chronic osteomyelitis and arthritis. Skin, alopecia and furuncle. Renal, UTI, that is urinary tract infections. Miscellaneous, otitis media, unilateral parotitis, purpuric eruptions, epistaxis and thrombosis. Investigations. So this is the famous mnemonic which everyone knows. That is for it is known as BASU. So first week B stands for blood culture. So in first week blood culture is positive. In second week A is for agglutination test. That is also known as Vidal, which is the most frequent investigations ordered by each and every practitioner. Third week is S, that is stool culture. Fourth week is U, that is urine culture. So BASU is a mnemonic for blood culture, agglutination test, stool culture and urine culture. So gold standard for diagnosis is blood culture. Vidal test, it detects presence of IgG, IgM antibodies to H flagellar antigen of Salmonella typhi and O somatic antigen common to typhi and paratyphi A and B. So we have already studied the somatic antigen O is common for all the serotypes of Salmonella and H is common for Salmonella typhi. So these, and whenever these antigens enter to the body, there should be a reaction from the body. That is, antibodies are produced in form of IgG and IgM. So now detecting this IgG and IgM will help us in demonstrating the test. If you detect IgG or IgM, that means there is H antigen or O antigen, and that means the patient is positive for typhoid. So anti-O titers are both IgG and IgM that rise and decline early, whereas anti-H is only IgG that rise and decline late in the course of the disease. So what is the conventional method of interpretation? You are doing a baseline Vidal today in the first week, and you will be doing this after 1 week. You'll be repeating the test. Then if you see a fourfold rise between the two samples, this is then it is considered as positive. This is the conventional method of interpretation, but this cannot be possible, as even because first child will be having 2 pricks because of that, and second parents will not accept for that. Parents get anxious and they will ask us, why are we repeating the same test again and again? So for the practical purpose, we take only single titer done in second week of illness, and if it is 1:160 for both O and H antigen, it is considered as positive. A test has several limitations. Sensitivity and specificity is low. Why sensitivity is low? First of all, I already told, first week blood culture is positive. Second week agglutination, that is Vidal, is positive. If you are doing Vidal test in first week of illness, then Vidal will be negative. Why? Because you at least need 1 week to produce antibodies against the antigens already present in our body. So we are not giving the time to the body to produce the antibodies. So in the first week of illness, if you are doing Vidal, it will be negative. And in patients treated with prior antibiotics, if you have already treated the child, so obviously the test will be negative. Specificity is low owing to anamnestic reactions, prior vaccination, cross-reactivity with other Enterobacteriaceae and subclinical infections in endemic areas. So false positives. This is the same repetition of the previous slide. So immunization with typhoid vaccine. So we are giving immunization with typhoid vaccine. So the child may be positive because of the antigens which we have injected, and we'll be thinking it as typhoid. Repeated subclinical infections. Repeated subclinical infections will all because of that subclinical. What does subclinical word mean? That That means the patient has not presented with symptoms or signs as expected. It was subclinical. Patient's immunity was good to produce the antibodies and limit the infection. So if repeated subclinical infections are there, antibodies are also already present, so the test might be positive. Past clinical infection. We also know that antibodies doesn't disappear in one day, and there might be a memory also. So past clinical infection will produce false positive. Healthy carriers of salmonella typhi, anamnestic response, and patients of cirrhosis and hepatitis. False negative. Too early collection of blood samples. See, if you have collected the blood in first week, then the report will be negative. Patients on antibiotics, we have already treated the disease, so the patient will have false negative. And 5 to 10% do not respond by antibody formation. What are the other investigations done? So normally this what always read till now are the specific investigations for typhoid, that is blood culture, Vidal, everything. But a child presents to your OPD with fever, you don't advise only Vidal or blood culture. We do the remaining tests also, that is complete blood picture. So in complete blood picture, anemia and thrombocytopenia are present in advanced illness. That is after when the child enters into complications or something during that time. Leukocyte counts, which might be normal or low or increased. So there is no definitive pattern of leukocyte count. And differential leukocyte count, there you might have eosinopenia and neutrophilia. Liver function tests, a mild elevation of transaminases. I already told that typhoid affects all the organs of the body, but it multiplies in liver and spleen first. So liver is also affected. So there will be mild elevation of transaminases. High CRP C-reactive protein rules out viral infections. CRP is more for bacterial infections than viral infection. USG abdomen, you will have mesenteric adenitis with splenomegaly. So, first, if you see a child presents with fever for more than 1 week, having toxic look, abdominal pain, diarrhea, coated tongue, hepatosplenomegaly, goes in favor of typhoid. Antibiotic resistance. Antibiotic resistance is not only for typhoid, it is present for almost all the diseases. We have importantly read about antibiotic resistance for TB. Everywhere we have read about tuberculosis, antibiotic resistance, multi-drug resistance, extensive drug resistance. All those things we have read for TB. It's the same for typhoid also. There is multi-drug resistant typhoid fever. It is resistant to all the drugs that were used as first-line treatment. First-line treatment when typhoid was diagnosed in 1970s. First-line drugs were chloramphenicol, sulfamethoxazole trimethoprim, and ampicillin. And these drugs, bacteria started developing resistance. So then we introduced fluoroquinolones, was started as first-line treatment. But now Salmonella typhi is developing resistance even for fluoroquinolones and nalidixic acids. But interestingly, surprisingly, Salmonella typhi has become sensitive to the first-line treatment which was used earlier. That is for chloramphenicol, cotrimoxazole, and ampicillin. But use of these chloramphenicol, ampicillin, cotrimoxazole is limited because of the toxicity caused due to the drugs, side effects due to drugs. There are recent sporadic reports of resistance to ceftriaxone due to production of beta-lactamases. Ceftriaxone is one of the important drugs in cases of severe typhoid, which we will be giving IV intravenously, which we'll be discussing in a bit of time. Treatment. Indications for inpatient treatment. When will you admit the patient and treat? If the child is eating properly, taking tablets properly, and has no vomiting, there's no need for the child to get admitted. So in when will you admit a child? When the child does not respond to your primary therapy. Development of complications. Child has developed vomiting, persistent vomiting. You give a tablet, child will vomit. When child is not able to digest the tablet, so in that case we need to admit. Poor oral intake and severe diarrhea or abdominal distension usually require intravenous antibiotics and IV fluids, necessitating admission to the hospital. So antibiotic therapy. First, you send blood culture. In the first week, however, blood culture should be positive, so you send blood culture. After blood culture, if you're suspecting strong clinical suspicion uh, with the features of fever, stepladder type, high grade fever, uh, not responding for more than 1 week of duration, hepatosplenomegaly, coated tongue, sick looking, may be associated with diarrhea or constipation, vomiting. Strong clinical suspicion of enteric fever. We will start with oral cefixime, 20 mg per kg per day is the drug of choice. Azithromycin, 10 to 20 mg per kg per day is the second line of drug. For uncomplicated enteric fever, that means the child is treated at home. So we'll be giving oral cefixime and azithromycin. Chloramphenicol, amoxicillin, and cotrimoxazole are the other second line drugs. For severe illness and where complications are present. Severe illness, that means child is not able to take orally, is not able to take tablets, and or else he has not responded to your primary therapy and landed up in complications. In these cases, you need to admit the child and give proper hydration, and start intravenous ceftriaxone 100 mg per kg per day or cefotaxime 200 mg per kg per day are used. In patients with history of penicillin or cephalosporin allergy, aztreonam, chloramphenicol, and cotrimoxazole are used as second-line agents. So, parental treatment. Till when you will continue the parental treatment? The child will respond within 5 days to your intravenous antibiotics. Maximum 5 days, 3 to 5 days. So, in that situation, we will add parental treatment. So if the child has responded and started taking orally, we'll stop the parental treatment then and convert the child into oral treatment. Then we will give Anushka. Ninna. Sorry for the interruption. So, parental treatment is continued until oral intake has improved and complications are resolved. Thereafter, therapy can be switched to oral cefixime to complete the total duration of 14 days. And other oral drugs used to switch over therapies azithromycin, cotrimoxazole, and amoxicillin. So normally the child should respond within 5 days. If the child does not respond for 5 days, then we will add a fluoroquinolone, that is Oflox or levoflox. Ofloxacin is commonly used after 5 days for the treatment, for the child to respond, because there might be some resistance to the antibiotic which we have already started. So, when the child does not respond, in culture proven typhoid fever, if the child does not respond within 7 days, we need to think of other causes. That is drug fever, thrombophlebitis, hepatic or splenic abscess, hemophagocytic syndrome, and co-infection should be ruled out. So, if the child has landed in complications, child will not respond. If it is not culture proven typhoid fever, then think about other causes. Relapse. So, relapse occurs in treated cases due to the organism with the same susceptibility as original attack and is relatively milder illness. So, in relapse, it is relatively milder the disease course is relatively milder, and the child is having susceptibility to the same susceptibility as original attack. So the child will respond to the same antibiotics. That is, relapse is higher with lactams such as cefixime or ceftriaxone as compared to quinolones or azithromycin. So, in relapse, normally on first admission, as I already told, if it is uncomplicated, we start with cefixime, and if it is complicated, we start with ceftriaxone. This is very common, and this is what usually it takes place in the wards. So, with cefixime and ceftriaxone, there is more chances of relapse as compared to quinolones or azithromycin. In relapse, the patient is susceptible to the same antibiotic. If you start against ceftriaxone or cefixime, the child will respond and will come out. So, we can start the same antibiotic, but azithromycin is preferred as relapse rates are less compared to the cefixime or ceftriaxone. Carriers. Adults may shed salmonella in stool for 3 months after an acute attack, and some may shed up to 1 year. So, why is this important? There is no evidence of carriers prevalence in children, but yet we should know something about carriers because children live with adults. So, adult and it is spread through fecal route, and there should be hygiene maintained. If hygiene is not maintained, there due to adult shedding the salmonella for 3 months or 1 year, they might infect the kids in the family. These individuals, these adults are potential source of infection for family members, contacts, and community if they are involved in works like food processing. So, if these people are working in some carrier company or food processing companies, they might spread salmonella. This you would have heard about typhoid Mary. Typhoid Mary is one of the carrier who has spread to thousands of people. Uh, she was a carrier, but she didn't know that she was spreading, but she was spreading. Prevention, you have to improve hygiene and sanitation, and vaccine. There are vaccines for typhoid. Uh, so we'll see a bit about typhoid vaccine. Uh, there are 3 typhoid vaccines. That is VI capsula polysaccharide, typhoid conjugate vaccine, and live attenuated typhoid 21. First, we'll see about live attenuated typhoid 21A because that is not available in India and it is an oral capsule and 3 doses should be given. And as it is oral capsule, you need to swallow it. If you are not swallowing it, due to gastric barrier, the efficacy of the typhoid 21A will get reduced. So when a child can swallow, that is above 6 years. So below 6 years, live attenuated typhoid 21A is not that useful. So 3 doses who can swallow, it is given above 6 years. And catch up can be given at any age for live attenuated typhoid 21A. Adverse reactions are abdominal discomfort and fever. Contraindications, live attenuated vaccination, always the contraindication for is immunodeficiency. So in immunodeficiency, you should never give live attenuated vaccines. Storage is at 2 to 8 degrees centigrade. Efficacy is 50 to 60%. So VI capsula polysaccharide and typhoid conjugate. These are available in India. Live attenuated is not, typhoid 21A is not available in India. What is the dose and route? For VI capsula polysaccharide, it is 0.5 ml subcutaneous or intramuscular. Site is anterolateral thigh or deltoid. These vaccines are not included in national immunization schedule. They are included in Indian Academy of Pediatrics schedule. So VI capsula polysaccharide is given at 1 dose more than 2 years of age. Repeat every 3 yearly if conjugate not available. If typhoid conjugate vaccine is not available. Catch up, you have to give 1 dose beyond 2 years. Adverse reactions are local pain, swelling, redness, and fever. Contraindications, Anaphylaxis after previous dose. Storage is 2 to 8 degrees centigrade. Do not freeze. Efficacy is 50 to 75%. Typhoid conjugate vaccine. 0.5 ml intramuscular. Anterolateral site is anterolateral thigh or deltoid. In IAP schedule, it is included at 6 months of age. Catch up 1 dose up to 18 years. Adverse reactions, that is local, same as VI capsula polysaccharide, that is local pain, swelling, redness and fever. Contraindication is anaphylaxis after previous dose. Storage is 2 to 8 degrees centigrade. Efficacy is 80 to 90%. Conjugate vaccines are preferred over polysaccharide vaccines since they generate strong anamnestic response and show prolonged immunological memory. So conjugate vaccines will show prolonged immunological memory. So typhoid conjugate vaccine is included in IAP schedule at 6 months of age. 1 dose, 6 months of age is over. Whereas polysaccharide vaccine, if you want to give, you have to give above 2 years of age and you have to repeat the dose every 3 years. For typhoid conjugate, there is no need to repeat the dose. So take home message. In India, the most common cause of pyrexia of unknown origin is typhoid. Salmonella enterica var typhi or paratyphi is gram-negative, non-lactose fermenting flagellate bacterium with somatic O antigen and flagellar H antigen. Somatic O antigen is common for Salmonella typhi, paratyphi, whereas H antigen and VI polysaccharide is specific for Salmonella typhi. Mode of transmission is fecal-oral route. Incubation period is 7 to 14 days. Pathogenesis. Bacteria reaches small intestine and penetrates lymphoid tissue, reaches liver and spleen. There it multiplies for 7 to 14 days. Then it is released again into bloodstream, reaches liver, spleen, Peyer's patches, and will start clinical manifestations. Always remember the infective dose is reduced if the child is on antacids or proton pump inhibitors. This will reduce the infective dose as the gastric barrier, that is the acid production, is less. So the organisms are not destroyed and so infective dose is less. Step ladder type of fever is a hallmark. Examination is coated tongue, relative bradycardia, hepatosplenomegaly, rose spots. Rose spots are not seen in Indian children because of the complexion of the Indian children that is mostly seen in Western countries. Typhoid affects almost all the systems. It not only affects the intestine, it affects almost all the system. You add itis to anything, then it will cause the disease is there. Just like for CNS, it causes encephalopathy, RS bronchitis, CVS, it causes myocarditis. In GIT, it might cause hepatitis, cholecystitis, intestinal perforation, peritonitis, bleeding. All are the complications for GIT, and it might cause osteomyelitis for bone. So, and the commonest intestinal complications which we have studied, that is bleeding and perforation, are rare in children. Investigations. BASU is the mnemonic. First week is blood culture. Second week is agglutination test, that is Vidal. Third week is stool culture, and fourth week is urine culture. Blood culture is the gold standard for typhoid diagnosis. Vidal is done in second week of illness. It has low sensitivity and low specificity. So, if done in the first week of illness or if the child is on prior antibiotics, Vidal will be negative. So there are many false positives and false negatives. Treatment for that is in uncomplicated cases, it is cefixime or azithromycin for 14 days, and in complicated cases, injection ceftriaxone and cefotaxime till the child accepts orally. When the child starts accepting orally, we will shift them to the oral therapy, that is cefixime, and the total duration of therapy is 14 days. Relapse is higher with beta-lactams such as cefixime or ceftriaxone as compared to quinolones or azithromycin. Relapse treatment. Relapse, children will be susceptible to the same antibiotic again. We can give ceftriaxone or cefixime, but we prefer azithromycin as the relapse rates are less with azithromycin. There is no evidence of carriers in children. Prevention, we have to improve sanitization and hygiene and sanitation too. And vaccine, typhoid conjugate vaccine is included in IAP schedule at 6 months of age. There is no need for boosters. And whereas VI polysaccharide vaccine, capsula vaccine is also included in IAP schedule, which can be given at 2 years of age, after 2 years of age, and you need to repeat it every 3 years. And live attenuated typhoid 21A vaccine is also available. It is an oral vaccine. It is given only in children above 6 years who are able to swallow it, and it is not available in India. So we are not bothered much about it. We should know about the typhoid conjugate vaccine and VI polysaccharide vaccine. Thank you.